We're now going to move into our first symposium. I'm going to welcome Matthew Hotopf and Kirsty Stanley, who will chair this symposium entitled "What Have We Learned from COVID-19 About Mechanisms of Mental Health?" Direct effects of the infection with SARS-CoV-2, including the body's inflammatory response, as well as the indirect effects from pandemic containment measures such as lockdown. Our two chairs then. Matthew is Director of the NIHR Maudsley BRC and Vice Dean of Research at the Institute of Psychiatry, Psychology and Neuroscience of King's College London. And he's a member of the Academy of Medical Sciences MQ Working Group that in the autumn spoke to the House of Lords Committee on Science about the impact of the pandemic on mental health. He's joined with his co-chair, Kirsty Stanley, who's an independent occupational therapist and writer. She herself has experienced long COVID and is a member of the long COVID support group. I'll hand over now to lead us through the symposium. Matthew and Kirsty, over to you.
Good afternoon, everybody. My name is Kirsty Stanley, and I am one of the members of the Long COVID support group and part of the employment advocacy group there. I'm also an occupational therapist by background, and I have lived experience of mental health problems. I have long-standing depression, and I was actually diagnosed with ADHD at the end of last year, so virtually, because that's how everything is happening nowadays. And I'm really looking forward to seeing what COVID-19 has taught us about mental health. I think there's some stuff that I'm aware of from a lived experience and also from an occupational therapy perspective also. Thank you.
And hello, everyone. My name is Matthew Hotopf. I'm Director of the Biomedical Research Centre at the Maudsley and Vice Dean for Research at the Institute of Psychiatry, Psychology and Neuroscience. My background's as a psychiatrist and epidemiologist, and I was part of a group which you've heard about already, which put together a research agenda, as it were, for exploring the mental health impacts of COVID-19. And it's been very gratifying that that has had some traction, and to hear a bit about some of the people who have picked up the baton, as it were, and conducted research in this area.
Okay, so the first speaker today is Katherine Young from King's College London.
Go.
Hi, thank you so much for the invitation to speak today. I'm really pleased to be sharing with you some findings from our work examining changes in depression, anxiety, and PTSD symptoms from before to during the COVID-19 pandemic. During the pandemic, I've been working on two studies examining mental health during the pandemic, the RAMP and coping studies. And in combination, we've been monitoring mental health in over 30,000 individuals from all across the UK. Today, I'm going to be talking specifically about findings from around a third of this sample in whom we had pre-pandemic mental health data available. This was through these participants' involvement in the Genetic Links to Anxiety and Depression, or GLAD study, run by my colleagues, Professors Gerome Breen and Talia Ely at King's. The GLAD study is a large recontactable cohort of participants who have prior experience with anxiety disorders or depression. Within the sample, we've been looking at two main research questions. First, examining changes in mental health from before to during the pandemic. We've been exploring this question in a few different ways. And secondly, to look at individual difference factors to try to identify groups of individuals who might be at greatest risk of worsening mental health during the pandemic. So thinking first about overall changes in mental health. As I mentioned, we've been looking at this question in a few different ways, and the simplest approach we took was to ask people a single item question about how different their symptoms of anxiety or depression feel currently and this was measured in May or June 2020, compared to how they remembered feeling before the pandemic started. So as you can see from this figure, when we ask this question, we see that around 60% of our nearly 13,000 participants reported worsening anxiety or depression, whereas 25 to 28% report no change in symptoms, and 10 to 12% actually report an improvement in symptoms. The second way, next slide. The second way we've been looking at this data is to think about measures on symptom scales. So we had participants complete symptom measures during May and June 2020. This is the during pandemic data here. And the same participants also completed measures of depression, anxiety, and PTSD symptoms when they initially signed up to the GLAD study. And this could have been at any point between September 2018 and early 2020. So the plots here are showing somewhat of a different story to what I showed on the previous slide, where we see very minimal changes in symptoms from before to during the pandemic. And on these scales, a score of around 10 on the depression or anxiety measures and around 15 on the PTSD measure indicate sort of moderately severe symptoms. So what we see is a very marginal overall decrease in symptoms of depression and anxiety, and a marginal overall increase in symptoms of PTSD. And this is quite notably different to the 60% of individuals who reported a worsening in their mental health. And so what this might suggest is that even though a high number of individuals might be experiencing a worsening in mental health or heightened psychological distress during the early months of the pandemic, this didn't immediately translate into an overall worsening in symptoms. The third way that we've been looking at changes in symptoms of depression or anxiety is to ask people to recall how severe they remember their symptoms being before the pandemic. And this finding sheds a little bit of light on this discrepancy that I've just presented in the first two slides. So here I'm showing you the same data as the previous slide in yellow and green, our pre-pandemic and during pandemic data. But what I've added in pink is retrospective estimates of how severe people remember their symptoms being prior to the beginning of the pandemic. So what we can see is that pre-pandemic retrospective symptoms are substantially lower than either pre-pandemic symptoms or symptoms measured during the pandemic. And this suggests that we might have a tendency to underestimate past symptom severity. So if we're not accurately recalling how bad our symptoms were in the past, it's plausible that we might experience a worsening in our mental health, even in the absence of an overall change in symptoms. Of course, this is only an early time point within our work, and we're currently working on later data to examine whether initial experiences of worsening psychological distress translate into changes in symptoms in the longer term. At the same time, looking at overall means is really only part of the picture. And although there are minimal overall changes in our data, when we look at individual differences, we do see that many people experienced worsening of symptoms, as well as many people who experienced an improvement in symptoms. So we've been looking at a range of individual difference factors to try to identify groups who might be at greater risk of worsening mental health. And here we're looking at changes from pre-pandemic to during the pandemic data, measures of depression, PTSD, and anxiety symptoms. And in each of the plots I'm just going to show you, any point to the right-hand side of the dotted line indicates greater likelihood of worsening symptoms, whereas anything to the left-hand side indicates greater likelihood of a decrease in symptoms. So thinking first about mental health diagnoses and neurodevelopmental diagnoses, what we see is that a range of mental health diagnoses, including comorbid depression and anxiety, eating disorders, OCD, PTSD, and personality disorders, were associated with increased risk of worsening symptoms. Among neurodevelopmental diagnoses, autism spectrum disorder was associated with increased risk of worsening depression and anxiety, whereas there was no significant effect of an ADHD diagnosis. Looking at gender and age, we see a significant effect of female gender on PTSD and anxiety symptoms, and really quite a striking effect of age, where young people aged 16 to 25 years were at elevated risk for worsening symptoms, whereas individuals aged 46 years or over had a greater likelihood of showing a reduction in symptoms. And looking at the effects of ethnicity, we see no significant differences, although we should note that we are relatively underpowered to detect differences amongst minority ethnic groups. And this is something to be examined more closely in a more ethnically diverse sample. And finally, looking at the effects of employment status, we saw that elevated risk of worsening depression amongst students and worsening of all symptoms amongst individuals who are unemployed. So moving forward with our data, we're planning to examine longer-term changes in mental health, as well as the role of potentially modifiable risk factors, certain types of thoughts or behaviors that we may engage with in response to stress. And we hope that this will help inform our understanding of the pathways from going through a stressor to ultimately experiencing a change in mental health, to help identify key strategies for supporting those at greatest risk in the future. I'd like to thank you for your attention, and I'll finish there for today.
Okay, and I'm delighted to welcome ElisePaul from University College London as our next speaker.
Hi, thank you for having me. I'm ElisePaul, and I'm a Senior Research Fellow in Epidemiology and Statistics. And today I'm going to present some findings on mental health from the UCL COVID-19 social study. So the UCL COVID-19 social study is the largest in the UK, looking at psychological and social impact of the pandemic. We started data collection on the 21st of March last year, so just days before the lockdown, the first lockdown in the UK, and we've been collecting weekly data ever since. To date, we've collected data from over 72,000 participants, totaling nearly 1 million surveys, and the online survey is complemented by a qualitative component, which consists of in-depth interviews so that we can gain deeper insights into the ways in which people have been impacted by the pandemic. So the mental health measures we've been collecting weekly are depression symptoms with the Patient Health Questionnaire, or the PHQ-9, anxiety symptoms with the Generalized Anxiety Disorder 7, or the GAD-7, as well as questions on self-harm, thoughts and behavior, and the use of mental health services. And I've highlighted depression and anxiety symptoms so that you'll know that these are the ones that I'm going to focus on today. So in addition to these mental health measures, we've also been collecting data on a range of other factors, such as time use, adverse experiences, health and social behaviors, and psychological factors. So the first finding I'd like to share with you is from our most recent monthly report, which we publish on our website. And like I said, we've been tracking depression and anxiety symptoms weekly since the start of the pandemic. So what we found is that overall, although there have been fluctuations in the average number of depression and anxiety symptoms that people have been reporting, they have also been consistently higher than what other population-based studies reported before the pandemic. So you can see in this graph that depression and anxiety symptoms were highest right at the start of the first lockdown and then decreased over the summer. However, since the autumn, the average number of depression symptoms reported by the people in our study has been around 5 to 6, whereas before the pandemic, other studies reported averages of about 3 or 4. Similarly, the average number of anxiety symptoms reported by people in our study have been hovering around 4 compared to about 3 in other studies pre-pandemic. So because we started data collection in March of last year, we unfortunately don't have data from before the pandemic. So we can't be certain that these are increases that are due to the pandemic. However, there is recent systematic review evidence of longitudinal studies indicating that depression and anxiety have in fact increased during compared to before the pandemic. So the second finding I'd like to share comes from one of our papers that was published last year in Lancet Psychiatry. And the findings indicate that some groups have been more adversely affected in terms of their mental health than others. So the graphs you see here are from latent growth models that account for sociodemographic and health factors. And the models characterize trajectories of people's depression and anxiety symptoms over the first 20 weeks of the pandemic. So in the top two graphs, you can see that young adults, or those aged 18 to 29, have consistently been reporting higher depression and anxiety symptoms than older adults. And similarly, in the bottom two graphs, you can see that women have also been reporting more anxiety and depression symptoms than men. And so although these data are from what we would now call early in the pandemic or over the first 20 weeks, our monthly reports up until last month indicate that these trends and differences between the groups have continued to exist. So these graphs are from the same publication and show two additional groups whose mental health appears to have been more adversely affected. So in these graphs, you can see that people with incomes below £30,000 a year and people from ethnic minority groups have been consistently reporting higher levels of anxiety and depression symptoms. And again, this is after accounting for other sociodemographic characteristics and health factors. And again, although these data are from the first 20 weeks of the pandemic, our monthly reports indicate that these trends have continued. So the last finding I'd like to share with you is from a paper that was published recently in which we looked at factors influencing increases or changes over time in people's anxiety and depression symptoms. And this was conducted over the first few months of the pandemic. So not only have we been collecting data on mental health factors, as I said, we've already also been collecting data on different adverse events people may have experienced in the past week, as well as whether or not they're worried about experiencing these adverse events. So the adversities and worries in this particular set of analyses were selected to complement each other. So for example, experiencing job loss was included in the total number of adversities, and worrying about losing one's job was included in the adversity worry scale. So these graphs show standardized coefficients from fixed effects models, which looked at changes over time in the total number of adversity experiences and worries about adversity with changes in anxiety and depression symptoms. And the main finding here is that in the pink triangles, you can see that when we account for both adversities and worries in the same models, there's no difference in the magnitude of associations between worrying about adversities and actually experiencing these adversities. If you look at anxiety, worrying about adversity is actually more strongly related to increases in symptoms rather than the number of adversities experienced. We then wanted to unpack in the same paper which specific adverse events and worries were driving these increases in depression and anxiety symptoms. And if you look at the orange triangles, you see that worries about all types of adversities showed associations with higher levels of depression and anxiety symptoms, whereas only experiences of adversities relating to accessing food, medication, and personal safety, which is psychological or physical abuse, were also associated with these outcomes. So the factor with the strongest association with both mental health outcomes was experiencing physical or psychological abuse, which is labeled in this graph as personal safety. A second interesting finding here is that the actual experiences of losing one's job or financial difficulties, which are the blue circles labeled employment and finance, were not associated with either depression or anxiety symptoms, but worrying about losing one's job and worrying about financial trouble were associated with these outcomes. So in sum, we've found that mental health does appear to have been adversely affected by the pandemic, and some groups have been more adversely affected than others. Young adults, women, those from ethnic minority backgrounds, and people with lower incomes have fared worse in terms of their mental health. We've also found that worrying about adversity seems to be impacting mental health just as much, if not more, in the case of anxiety, as actually experiencing adversities during the pandemic. And so moving forward, there's a need for monitoring of the mental health in the general population as the pandemic and the long-term consequences, social and economic consequences of it continue to unfold. I would like to thank all of our study participants for their time in taking part in our study, as well as our funders and to every researcher working and collaborating on the study. Thank you.
And huge thank you also to Gerome Breen from King's College London, who's up next.
Good afternoon. It's my pleasure today to talk to you about our studies of psychiatry and neurology during the COVID-19 pandemic. I'm going to talk to you about a project called the COVID-19 Clinical Neurosciences Study today. We know that COVID-19 has both psychiatric and essentially brain pathology and neurological outcomes for many patients. So up to 20% of people admitted to hospital have these outcomes. And furthermore, we think that a large proportion of the individuals who will end up with long-term disability due to COVID-19 will have had these complications. Perhaps most interestingly is that we have essentially a balance of neurology and psychiatric effects in hospitalized COVID-19, with younger patients especially having neuropsychiatric complications and older patients having more neurological complications, particularly cerebrovascular complications. So the COVID-19 Clinical Neurosciences Study is a collaboration across the country of around up to 20 centres now. It's led by myself and Ben Michael in Liverpool, and is a collaboration across neurology and psychiatry, as well as many pieces of research infrastructure around the UK, including the NIHR Bioresource, as well as ISARIC 4C. The research question in the study is, what are the clinical characteristics and mechanisms of acute COVID-19 neurological and psychiatric complications? We want to identify who is at risk, what are the medium-term sequelae, and develop an understanding of the mechanisms, because we think understanding these mechanisms will provide targets for therapy. And it's worthwhile bearing in mind that this will not be the last respiratory pandemic that we see in our lifetimes. So actually, we must take this opportunity now to develop understanding. Our recruitment and methods is outlined on this slide. Essentially, we wish to recruit and reasonably intensively characterize 800 cases with a neurological or psychiatric complication while they were in hospital with COVID-19. We'll compare them to a control group, as well as a large study in the community, the coping study that Katie Young talked about earlier. We're harmonizing our methods and phenotyping with the FOSP-COVID study. We're actively doing recruitment for COVID-CNS at the moment. So actually what I'm going to present to you now is some data from our coping study. So Katie outlined this already. Essentially, we're following, roughly speaking, 30,000 people throughout the pandemic. We've got 20 waves of assessment. We're doing broad phenotyping for psychiatric outcomes and neurological outcomes. One of the things we wanted to look at was to establish the parameters that might be related to long COVID in our cohort. And so a preliminary analysis is looking at the chronic fatigue scale within our data. So in an early freeze of the data, we identified 775 probable COVID cases, and as well as 12,200 unaffected individuals. We looked at the rate of chronic fatigue identified in COVID cases, and it was 48.6% in the first 6 weeks, whereas in non-COVID it was 28%. That gave an odds ratio for chronic fatigue due to COVID or correlated with COVID of 2.41. Now, one thing is that we have a lot of people with mental health diagnoses in coping because we recruited from pre-existing cohorts of people. But we also recruited pre-existing controls from the NIH or bioresource. So if we just look at them, we had about 336 COVID cases. The rates of chronic fatigue were lower in this group. So there were about 26% in the COVID cases versus 14% in the non-COVID cases. But the odds ratio was relatively similar for chronic fatigue. It was about 2.08. My general conclusion is that previous mental health diagnosis is a significant risk factor, but it's not the only risk factor for chronic fatigue or indeed for long COVID. Another analysis we've done, which I think I may or may not have time to explain properly, is Mendelian randomization to try and identify biomarkers for COVID-19. We used a genome-wide association study of death or needing intensive care from COVID-19, and we compared that with genetic data from 4,000 blood proteins. We've used this to identify candidate blood proteins to examine in our COVID CNS study. And notably, we identified the C4a, C4b protein dimer, which is also associated with schizophrenia and Parkinson's as predicting death or ICU from COVID-19. And we think that many of these proteins are potentially neurologically relevant, and we're going to be looking at them. Finally, just thanks to literally the cast of hundreds of people involved in the project. It's truly an awesome project to be involved in, and it's wonderful to see how the neuroscience community has come together to do this project. Thank you.
And next, I'm delighted to welcome Katherine Abel, an old friend and colleague from Manchester University,